What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. Brett, we're used to doing in-person stuff. This is our first Zoom in a long time, but we couldn't help. We kept putting it off and hoping that we could see this man in person, but
we finally gave up.
Yeah, we finally gave up.
We got to get him on.
We got to make this happen. So we're lucky to be sitting down with the one and only Michael Shacklock. So the guy that literally wrote the book on neurodynamics. So you've had an amazing story of what got you here, working up patients with a close personal friend, Dave Butler, like all these awesome things that we've kind of discussed in our past. But would you give us just like your 30-second or, your little elevator pitch of what is neurodynamics and what fascinated with you so far?
Thank you. Yes. For me, neurodynamics, it's a broad term that is not well defined, but for me, and in the context of physical health sciences, it's the application of mechanics and physiology of the nervous system. We know that the physiology changes with mechanical changes, and that can hurt with movement. And so it's the emergence of those two because they're dynamically interdependent. But beyond that, clinical neurodynamics considers the functional disturbances related to all this. So we categorize them and then we treat them according to their functional disturbance or the mechanisms. And that's really diagnosis. So for me, it's a diagnosis and treatment system for neural problems that have a movement-related aspect to nerve pain.
Beautiful.
So a lot of our listeners, they've been trained in NDT or they're at least familiar with the principles of NDT. What do you think, what does neurodynamics offer that maybe the typical McKinsey protocol might not be able to help with?
Okay, so I'm not going to be talking too much about competing ideologies here, because after this, at a certain point in our seminars, people do sometimes start perceiving a conflict between the systems. And that's actually not my intention, because actually, if we're all looking at the same problem, albeit from different directions, they should work together. Otherwise, something's wrong.
They can absolutely work together.
Yeah.
Yes. And so one of the fundamentals between neurodynamics and McKenzie or physical treatment of the tissues around nerve, musculoskeletal, is that for a period of time, we consider a different model. Now with neurodynamics, there are two models. It's not widely understood really, but there's model A, which is cooperative, meaning if you fix musculoskeletal, it's good for the nerve. And a good example would be carpal tunnel syndrome, where there's pressure on the nerve due to anatomical or mechanical changes around the nerve. And when you take force off the MSK there, you also take force off the nerve. Good, they work together. Or if you do something bad to the musculoskeletal, such as get a fracture or posture or position, it increases pressure on MSK, but also on the nerve. So they're actually a cooperative system, but the spine in certain areas is different. That is model B. And that is fixed musculoskeletal, which could be an extension maneuver to help the disc, or even a flexion maneuver, whatever it may be. And that actually can irritate the nerve, because as you do extension, you are closing around the nerve and applying pressure to it. And so when you treat MSK, sometimes the models compete. So that's model B, the competitive model. So that unfortunately is the point of confusion or lack of understanding in neurodynamics and MSK. Excuse me. And so for a period of time, we can deliberately omit treatment to MSK when the nerve is really sensitive and doesn't tolerate force. And at that point, we would then, rather than do extension or closing, if we're thinking neurodynamically, we would do an opening technique just to transiently reduce force on the nerve root, give them relief, and then proceed from there into MSK when the patient tolerates it. So fundamentally, neurodynamics can be a lower progression of force, and in fact, you can unload nerve roots as opposed to loading with just treating MSK. Sounds a bit complicated, but the logic is if we're thinking of nerve radiculopathy, for instance, the most common cause in MSK circles is pressure, usually disc hernia. Mm-hmm. And the logic is, in terms of neuromobilization, let's mobilize the nerve. But that applies pressure to the nerve, force to the nerve. So I think at best, a lot of neuromobilization techniques in the past have produced adaptations rather than unloading and getting a bit closer to the cause, which is pressure. So a key point about neurodynamics is we unload them for first aid. As they're ready, we start rehabbing. And in the certain individual who has high function, we do performance with neurodynamics.
Well, I think that's an important point, Michael, because I think the world, in the world of rehabilitation and manual therapy, it's always so binary to me. Like it's either you're a neurodynamic case or you're over in the McKinsey hospital. So don't you think there's a place for both? So even if we had a centralizer that we were using, in a McKinsey protocol, at some point there would be a time that we would reintroduce neurodynamics into the treatment of that patient.
Yes. What can I say? the one word sums it up, and again, it's yes. And really, if you're thinking it intellectually right down to physically and biologically, they're all integrated. Look, no one walks to work doing a slider for the median nerve of the wrist. That is not a functional technique. It is something that stimulates changes, but it's not particularly specific to the problem. Whereas if you can get into mechanisms, clinical presentations, and tinker with them, or, as you say, as Professor McGill says, play jazz, you can move it around depending on mechanisms and patient presentations. And you've seen this, you've done it clinically, you've done something to a patient, and they've looked up and said, no one's ever asked me that before. No one's ever done that test before. No one's ever touched me or moved me like that before. Wow, it's getting at my problem. Now, N equals 1 is still a very important statistic, and that's where integration of approaches is really important.
Michael, could you speak about, because I think this is one of the main tenets of your seminars, which is the first thing is, and you use the term neurodynamic hospital, which we love. We always use it. We've stolen that term from you. How do we determine whether or not a patient is in the neurodynamic hospital or not? And why is that so important? Therefore, we're able to differentiate whether this could be like a nerve interface problem, whether this is, a sliding nerve problem, all these, different components. Why is it so important to determine whether or not they actually are a neurodynamic patient or not?
Yes, no, that's an excellent question. Thank you. Look, I think all systems have to have a number of things. And one of them is inclusion and exclusion criteria. People in the seminar business, professional seminars and so forth, they get accused of selling an approach. And okay, you're allowed to sell an approach, but I think you've got to say, well, got to be a bit careful here, because we don't want everyone doing this, because that excludes diagnosis. Diagnosis is about finding if a problem exists and dealing with it directly, and not other things. And so with neurodynamics, there are inclusion, exclusion criteria, which help keep credibility and integrity to the approach so that people don't get the wrong treatment and go to the wrong hospital, which would be neurodynamics hospital or musculoskeletal hospital. So if there were an exclusion criterion for neurodynamics, it would be a normal neurodynamic test. So if you do an appropriate test on a patient with sciatica, lumbar problem, and the straight leg raise is perfectly okay, it's the right test for the neurodynamic aspect to that patient, good, that's an MSK problem. You don't need to do neurodynamics today or in the near future. That's one less thing you have to worry about. And on Friday afternoon, you don't want to see neurodynamic problems. So it's actually better to put them in the musculoskeletal hospital and you only have to focus on one thing. And that's called diagnosis.
I have a great, you blew my mind the first time I saw you, Michael, and that I brought you a patient that it was a pain in my ass, pain down the leg, was not getting better with anything I did. And Michael did an extreme exam on him. I mean, he checked everything on this dude. Finally, he stood up in front of the class and you had 50 people around you and you said, I'm sorry, but this is not a neurodynamic problem. And the reason that stuck with me is because so many people in the seminar business would have found a way to include him in the model and then treated him, but you perfectly demonstrated your system and that it was an exclusion criteria in that situation and didn't fit the model. And so you gave suggestions on what to do next, but you purposely said, no, this is a neurodynamic seminar. This doesn't fit into what I'm teaching. Therefore, we're kind of done with it, and we had a great conversation about it afterwards. And he had some great tips for me with the patient, but I just thought that always sticks with me, even when I'm doing neurodynamics in the treatment room of like, okay, is this inclusion? Is this exclusion? What hospital am I in? And, we have great conversations about that same thing of like, okay, well, what hospital are you in? Are you in the right situation or you're in the right problem? So I thank you to that point.
Well, I think too, the irony is watching you work on your patients during your seminars is, I think the world that hasn't actually taken your coursework or seminars, a lot of times they would be trying to attempt to be doing aggressive neurodynamic treatment. And you would probably have them in like a static opener or something like that, letting the nerve kind of heal and calm down.
Which is, yeah, exactly. I think maybe that's a great question is like, at what point is rest? I know I'm actually looking at your neurodynamic sequencing progressions right now. Talk to us about that first protective rest. Like how important is that? And then what do you feel is the time frame or like, how do you determine that for a patient?
Yeah, that's a good question. Yeah, one of the key points I feel about neurodynamics is it actually includes, the normal logic that you would for MSK. Sorry. Now, the MSK logic is if something's acutely injured and it's got quite a nasty inflammatory or bleeding process, then you don't go. Someone who sprains their ankle at football isn't told to quickly jog home. They're told, okay, it's bleeding. You jog home and you might irritate it. So let's get you into a stable situation first, homeostasis or whatever, and then progress to rehab when it's appropriate. And same with many orthopedic injuries. But in neurodynamics, we haven't applied that logic. Oh, acute severe radiculopathy, sciatica. Let's mobilize the nerve root. Oops, too much. Then we've got to do something else. It would do MSK. And so one of the key aspects is it applies normal logic, but with different mechanisms. And so, as you say, you could calm the nerve root down, put it in the nerve root hospital for a short time. When that calms down through unloading techniques, the contralaterals, the openers, and so forth, and then they progress to rehab, which would then go back to MSK. And so to me, it's a really important approach, but it also applies a step into a different logic, which is sometimes nerve root response may become part of the cause for now. And we know that the nerve root the blood flow in the nerve root definitely changes with radiculopathy. And one of the changes can be congestion. And it's been shown that people with radiculopathy can have increased venous blood volume in the foramen. Now, that's fascinating because that means more stuff is in there than before. And that means the pressure is higher. So the response from compression produces pressure on veins, they dilate and increase the pressure more. So what we may be doing is actually just working on response, which has become part of the cyclic cause just at the moment. And so we might be reducing congestion or improving blood flow transiently, but that might produce a cascade of events which actually produces big changes in the nerve root. We know that if you take pressure off at surgery, then the radicular nerve conduction, electrophysiology improves within several minutes. And so these responses are often rapid, and we're working on a second layer of logic, which is sometimes response becomes part of the cause. So let's just unload the thing, see if we can improve their nerve root physiology and therefore pain. And maybe we can talk about our recent study at some point, which applies that logic and for which the results were really good.
Was it hard to apply the model? Obviously, you're just talking about like the nerve root and the IVF. So how much do the mechanics change in the periphery versus the spine?
That's a good one. Oh, you mean from model A and B?
Yeah, just in general. Yeah.
Yeah, okay. So
because I'm assuming you originally started with the model with, well, actually, I don't know this, but so the nerve root and the IVF and the whole concept of the static opener and things like that. Is that where that model started and then you went to apply it in the periphery, or was it the other way around?
Oh, I see. I must say, excuse me. I must say that the first time I started teaching that was the opener or unloading was in the lumbar intervertebral foramen. So I guess I have to say that it would start off in the spine, but then the logic then extended to the rest of the body.
So, and then another thing I've heard you talk about, it's in the first chapter of your book, is the Kingry Effect, where you have like an effect of it. You potentially have damage to a nerve root that could potentially be the answer, the reason why we have trigger points in the muscles that are being affected by the nerve root that's feeding those muscles. Could you speak about that? Because I think that's actually a really important idea or concept.
Yeah. Thank you. Yeah, Kingry is, I'm just using the word Kingry, K-I-N-G-E-R-Y, because that's the first author of the paper that I'm using. Now, the idea is that when you tap, one of the diagnostic criteria for physical testing of a nerve problem is Tinel's sign. So you tap a nerve and it can produce pins and needles, and that's thought to be a response to mechanical sensitivity in the nerve, because it might be either regrowing, ischemic, or and so forth, inflamed. Now, that's the afferent version in sensory fibers. But Kingry is a sensitivity in the nerve mechanically, but it goes outward. And so it's the outward version of Tinel's sign.
Right.
Now, the idea is that they tapped the ulnar nerve and looked at the EMG behavior in the muscles innervated by the nerve. So when they tapped the nerve, the EMG quivered, it became active, which when normally that would not happen. And so it's an outward version into muscle along motor fibers, which may affect muscle behavior, muscle spindle behavior, etc. And as soon as you get to there, you're kind of getting into trigger points, aren't you? Mm-hmm. And so it's the outward version of a neuropathy instead of the inward. Now, we often think the perceptual changes as inward, of course. I hurt, I have pins and needles, etc. when I move. But Kingry is the opposite. You might not feel it, but it could produce changes.
Do you think that's happening more often than people realize?
Yeah, I do. Yeah, I do. So if we take clinically, I've got no problem. If you find a trigger point, and I know that word, the label is controversial, I'm not going to debate that. But if you find an abnormality in a muscle, for instance, with palpation or your physical testing, it may have a neural element to it. And we did a study a few years ago where we looked at EMG. My colleague Marinko Rade, with whom I work up in Europe, he did a study on EMG measuring pec major, lower traps, upper traps, biceps and brachioradialis with a simulated Mills manipulation, and found that the change in the muscles in the elbow varied with the position of the neck with lateral flexion. So if you did ipsilateral lateral flexion with the simulated Mills minute, the muscles weren't as active. which means that the neural tension into that area reduced. So part of the protective mechanism with Mills through muscle was mediated by neural tension, literally. And so that's sort of touching on the subject of nerves and muscles relate, and you may change a muscle by doing something to nerve, not just local as well.
Yeah, that's fascinating. Mm-hmm. You, since there's going to be a lot of chiropractors listening to this, I know Jeffrey Bove had a big influence on your career, so I thought I'd give you a second just to kind of say how he influenced you. And what's funny is if you ask an American chiropractor who Jeffrey Bove is, I'm telling you, less than 1% know that name. Can you make an argument on why they should know that name?
Yeah, Jeff Bove, B-O-V-E, he's an American chiropractor. He ended up working at Harvard for quite a while at Beth Israel Deaconess Medical Center. And so he when my book came out, we ended up getting in contact, and he said, come on over. So we ended up in his lab looking at animals and stuff like that, on our short visits that I had. And he and I, developed quite a good connection there. And people out there, you should know about Jeff's work. He is one of my heroes, and that's because he's really precise. He's a truth-seeking missile, and he pulls no punches. Now, to me, that's what we need. And so he's also a great scientist. He's a bit quiet. I sort of feel like he's a bit quieter than I would be about discoveries. He showed that he with Mary Barb showed that you can change tissues, tissue pathologies by changing load on those tissues with daily activity. So and it's an animal model where if the animal it pulls on a lever to feed itself, it's a rat, and you change the stiffness of the lever, you change the tissue pathology. Now, there's a big school of thought out there. Pathology is not important anyway. Who cares? Well, that's true for some people. But what it also showed was that it also changed nociception and their pain behavior. And if you did manual therapy on them, their pathology formation and their pain behavior were different. Now, he also showed, and it was one of the formative studies in neurodynamics, and this is probably more important for neurodynamics than the earlier studies. He showed that dura, for instance, or perineurium, epineurium has nociception in it, and you can stimulate those nociceptors with high intensity force. So he rightly said the nerve of the nerve may produce nociception. And this is where the idea that original concepts of nerve pain were focused on the axons passing along the nerve, but not so much on the nociceptors innervating the connective tissues of nerve. And that's Jeff's work. He's basically shown that, certainly in terms of nociception, you can trigger nociception in peripheral nerve with high intensity force.
On that same note, changing musculoskeletal with manual therapy, stuff like that, does the nerve tissue change? What's actually changing in the nerve whether you're resting, whether you're, performing neurodynamics, manual therapy, that kind of stuff?
Good question. Truth is, we don't know, because it's really difficult to study. We know certain things up to a certain point, and most of that is what mechanisms relate to pain, particularly ectopic impulse generation. Like if you tap a nerve, there's a study done there quite a while ago now where they looked at people with neuropathies and neurological diseases and measured electrophysiologically their axon behavior with different loads. And they showed that the people with peripheral neuropathy had much more active axons with loading than people who didn't. And this is in vivo, it's real people with real symptoms. So that's kind of what we know up to that point. And the corollary is that if we mobilize a nerve or do something to nerve tissue, and they get better movement and less pins and needles with movement, then the mechanical sensitivity of that nerve has reduced, therefore the physiology has reduced. But to my knowledge, that's not actually been measured yet. So we've got up to the point of we know a lot about what problems occur, but we don't know so much about how they change with treatment. There's a fair bit of work in the animal literature with pain mediation with chemistry and histology, immunohistochemistry studies, but these animals are no longer moving. Because they've got their cells in a dish. We only know stuff up to a certain point. We're using extrapolations or corollaries or interpolations and so forth. So the idea is, though, that if you improve someone's movement with a neurodynamic test, then probably the mechanical sensitivity is improved. But my feeling is that we've got to get to physical stuff as well. And our group's shown with Marinko again, Olavi, that people who have lumbar radiculopathy have less spinal cord movement with a straight leg raise than people who don't. And this is where the politics of physical versus perceptual is becoming a little more closer now. For me, the divergence or the polarization is diminishing, and that's because we are now finding physical relationships to symptoms. That's a really important thing to discuss, because at the moment, a lot of people think physical stuff doesn't matter. To me, that's an aspect of some people's problems. But, which hospital do you place the patient in today in the individual? So if you take our studies on spinal cord movement with MRI, people who recover get a better cord movement that approaches normal as well. Now, that's interesting, because following these people with radiculopathy over 18 months, we still haven't established causal relationships. If, for example, if you see someone with pain has less cord movement with the same physical test between other asymptomatic groups, you can say, well, they might coexist, but who knows whether they're causally related. But what's interesting is that as their symptoms improve over 18 months, so does their cord movement.
You were kind of leading on to it a little bit there, Michael, but now we have the pendulum in rehabilitation and manual therapy is definitely swinging toward everything centrally mediated pain. So, and I mean, I think the three of us would probably argue that maybe it's swung too far. Can you kind of comment on that? Because I know your colleague, David Butler, has definitely gone, more all in on the centrally mediated pain, but I think we need to understand and realize that the peripheral mechanism can still be a pain generator. We need to we need to not forget about that, probably.
Yeah, look, for a while there, I confess, I was an anti-nociceptor. And I personally think that's not a very balanced position. I don't think it's fair on people who have painful discs and are told their symptomatic disc hernia is not hurting.
Right.
And I would rather see a patient, because we know that discs can hurt. We now know that if a disc hernia exists, doesn't always hurt, but if it coexists with instability, it is much more likely to hurt. So you've got the layers. You've got pathology doesn't always hurt, dysfunction doesn't always hurt, but when the two get together, it is a conspiracy, and those tissues should be put in jail. Okay, and they should be dealt with. That's my opinion. But there are other people who've got a different set of patterns, and now we're talking about nociplastic types and some problems that you can't easily relate to a specific disease or pathology or dysfunction. But that doesn't mean it doesn't exist. And we're learning over time that certain things do, certain things don't. And the bad news might be that if you're a nociceptive focus, then you miss out on some possibilities. But if you're a brain focus, you might miss out on the nociceptive possibilities. The holy grail and the silver lining here is that it means we have to be professionals. It means we have to examine. It means we have to test. It means we have to pay attention to our patient, and we have to develop our skills. And that is Gestaltian.
Well, I mean, I think we're back to assessment, aren't we? I mean, the assessment is what will help us tell that story. I mean, I just think that, as time goes on, especially in that world, as far as the centrally mediated pain, you have, two categories. You have patients that are there because, we have multi-layered problems. We have affective pain, we have central sensitization, that whole thing that we already know. But then we also have people that get there because they just haven't had good treatment. They haven't seen the right person to be able to sort their problem out well.
Yeah, absolutely. And someone like Shirley Salmon has shown that if you do the wrong thing according to a dysfunction, they don't get better as well. If you do the right thing, they do.
Mm-hmm.
Right.
And what's nice about it is it's not dramatic, it's not sudden, it's progressive as their dysfunction improves. And that's sort of active movement, it's changing tissue behavior and so forth. So, I admit that I was a centralist for quite a while, but I've treated people centrally, and it can obviously help some people, but there are other people who they do have a physical problem. They really do need to move better. They need to balance forces on their tissues. And unfortunately, it's actually really difficult to study. If you look at someone's tissue behavior, jeepers, that's difficult to study. But it's actually, if you put someone in functional MRI in the brain, that's not so difficult.
Right.
It's on image. And so if we get into the politic of brain versus body, obviously integrated in my opinion anyway, but there are concerns about some of the functional MRI studies that have been done on the brain and pain. And one of them is that it's a study by Tim Sullivan's group where they looked at did a meta-analysis of about 300 functional MRI studies to figure out what brain activities were closely associated with pain and not. And they bait, the amygdala, anterior cingulate, and so forth. And so they put them into a study where they got two groups of people and they measured behavior in these areas with brain imaging, of course. But what was fascinating is they got one group which was healthy and could feel pain if they were given a noxious stimulus. Another group who, given a noxious stimulus, would never feel pain. And compared the brain activity between the two groups. The people who never felt pain were the ones who had that condition, congenital insensitivity to pain. Now, these people are normal otherwise, emotionally, cognitively, motor, all the stuff. But they die of appendicitis and stuff because they don't realise they've got a problem. So they lack the ability to feel pain, and for them it's dangerous. They might burn themselves or whatever. What they found was when they stimulated these people noxiously, the healthy group said, yeah, that hurt, and the brain activity, the pain matrix activity or the amygdala, et cetera, was active. But in the other group that did not feel pain with the same stimulus, brain activity was the same.
Yeah.
Now So that kind of challenges the idea that there's a physical representation or brain behavior for an individual that you can actually map, because right now it's not being done.
Right. What is the role of nerve conduction testing for the average, practitioner that's out there in private practice? So I don't know how it is in New Zealand, but United States, it's probably not as big as it was 5 or 10 years ago, but it's still, it's still out there. So what is the role? When would you use it, or when would you recommend using it?
Sorry, I missed that. Using what? MRI,
nerve conduction testing.
Oh, of course. Yes. Of nerve conduction tests. Yes, that's right. My feeling is that it adds a layer of knowledge, but it doesn't give you all the information you need. And if we're thinking of gold standards, obviously nerve conduction tests are the gold standard for demonstrating pathology without looking at the axons with imaging, because it's a corollary, it's an interpretation, which is if impulses can't get through, there must be something anatomically wrong with the axons, and it might be at a fine level molecular, or it might be gross level, and so that's the gold standard. Now the other one is MRI, particularly for nerve roots, and MRI is much more popular for lumbar radiculopathy because you can't do H reflexes and Hoffmans and all these other things through nerve roots very easily because it's more complex and probably more costly, more difficult. So we only have the look, we don't have the function with lumbar radiculopathy. And so for me, I like nerve conduction tests, but on the basis that it's still only part of a problem, because it doesn't necessarily predict what's going to happen in response to treatment. And it's the same with neurodynamics. It's only a part of the issue. And we know people who can have normal nerve conduction but have abnormal neurodynamic tests. And Jeff Bove, as you know, has done studies on inflammation of the nerve. And we know that the nerve threshold to movement reduces, so it becomes more active, but they can conduct normally through that area. So the nerve conduction tests tend to be an indication of something that's more compressive or severe. But before you get there, you could have something more minor that could still be quite painful with movement from inflammation. So they assess a kind of thing, and it's only a part of the picture. Same with neurodynamics. You get an abnormal neurodynamic test, perfectly normal conduction, and vice versa. So you kind of have these sensitivity and specificity ratings when you compare one of those variables with the existence of a problem. And so I like them, but again, they're still only a part of the problem that indicates certain kinds of mechanisms.
In the continuum of treating a peripheral, when would you recommend that you would get a nerve conduction test? Like, are we using, after the case is failing, et cetera, or do you think it could be used before then, or it's just completely case dependent?
Yeah, look, I'm not very politically correct with investigations because I kind of think that if you can pay for it, and you want to see what your lumbar nerve root looks like or peripheral nerve, then I don't mind radiological imaging. Radio selfies for me, I'm okay with. It's not actually the picture, it's how you illustrate it and communicate that to the patient. And it's pretty much been shown. People who have chronic low back pain have not been imaged terribly because they're scared of moving because they haven't been reassured that something nasty is there. So I guess I'm not so politically correct with radiology, and I know the movement is away from worrying about pathology, but I like to have all information at my disposal.
Right.
I mean, if it's financially okay, ethically okay, and you present it appropriately, you use the information well, I'm happy to have them done. It's just the costs of insurance, and I know the US is very insurance oriented, of course, and same with here in Australia. The government's not going to be paying for everyone to have a nerve conduction test, and so there's a balance, and I think the pressure on balance comes from economics, not so much what's best for the patient.
So there's been probably less nerve conduction tests, maybe in the US the last 5 to 10 years, but we've had a huge resurgence in diagnostic ultrasound. How does diagnostic ultrasound affect the future of neurodynamics? Are you a big proponent of it? Are you using it?
Yeah.
What's your take on that?
Yeah, I'm a fan of imaging, but when used appropriately, ultrasound though is not particularly. It's not going to be very sensitive to certain mechanisms. So it's not going to tell you if a nerve hurts with movement. If you want to know if a nerve hurts with movement, do a neurodynamic test. But their ultrasound could be pretty good, or there's another patient who might have a really compressed nerve, swollen and everything, but their neurodynamic test might not be so bad. And so again, it's a layer. And I'm a fan of more information. If you can't make a decision, you can't base a decision on information if you don't have the information. So I like ultrasound, but it's not quite as sensitive as certain things. And you can certainly look at the movement as swelling and get an idea of physiology, but again, it's a layer. So the answer is I like it, but again, it has its limits.
How often are you having to work on the soft tissue container of the nerve entrapment? And I say this because recently we had Mike Leahy on our podcast, who's he basically started active release technique. And a part of that technique system is nerve entrapment, actually a pretty big part. So obviously in his world, he's going after the soft tissue component of the nerve entrapment versus in neurodynamics, it seems like we're working more with the actual nerve. How often do you feel the need that we would potentially be needing to do work on the soft tissues around the nerve?
Oh, look, that's heavily based on the evaluation, and that brings us to palpation. And so I'm a fan of hands-on, feeling what happens, listening carefully to the patient. And on the online stuff, the videos we have for palpation of nerves, one of the things I say, I'll give you a general explanation at the beginning. What's the role of palpation? What do we get from it? And one of the critical things is you can say to the patient, show me where it hurts with your hand. And you watch how they do it, because that's how you may need to palpate. And so they get their butt and they got the achy, breaky buttock pain and they push and they twist and they angulate their thumb to show you where they feel it. Watch carefully, do it with a patient. And sometimes they say, oh, you're the only one who's ever found it. That's what you need. And so palpation is really important. And how you do it is also really important. Now we get to the opposite side, which is, but it's not accurate, it's lack sensitivity, specificity. Well, it depends what you're comparing it with. If you palpate the hip for piriformis syndrome, of course you're not going to get a very good result because you're probably not on, you may not even be on the nerve, there's a lot of tissue around there and everything like that. But if you can angulate and press them with the right contact point over the sciatic nerve and reproduce their sciatica, N=1 is much more powerful than a large clinical trial. And so to me, get in there, be specific if necessary, and develop skills. To me, it's really, really, really important. You can't measure that. You can't study it. Of course, it's going to fail in clinical trials. But there's a study done by Anina Schmidt's group in the UK who showed that in people palpating nerve responses in asymptomatic subjects anyway, they were highly reliable. And so it can be done, and I'm a fan.
So I was kind of surprised the first time I took your course because originally going through David Butler's work, you were kind of led to believe in his original book in the early 1990s that I think it was called The Mobilization of the Nervous System, that, you know, you do a neurodynamic test to be able to determine where the entrapment site potentially is. But I think that's not exactly what you teach, and that's kind of a little bit of a fallacy, isn't it? Right?
Yeah. Okay. So we're kind of getting to, excuse me, you're very observant reading that part of his book. That was an idea, and I was involved in the development of that idea, whereby the idea was to change the sequence of the movements of the test to emphasize parts of the nervous system. So if you have a wrist problem with carpal tunnel mechanisms, the general standard test might not be very specific because it kind of moves the nerves generally. And actually, that's a good thing for general tests. But with someone who has a small wrist problem, that might be an upper limb sport with repetitive movement or whatever it may be at work, they often get smaller problems, harder to find. And so the idea was to focus the forces on the nerve of the wrist. And then by starting the neurodynamic test with the wrist, where you get more extension, and then complete the test by using other movements. That was called neurodynamic sequencing. The idea was that we might be able to find where the problem is, but we've done some microstrain stuff in fresh cadavers and measured some of these things, and we didn't find that to be completely successful. That's a good way of putting it. Now, the other problem is that the study that collaborate with some people who have done studies that are not yet published on this, and they basically show that in people with carpal tunnel syndrome, if you do a wrist first sequence, you've got much higher sensitivity ratings than if you don't. So the problem for me is not that it's not useful. It's how do we, let's understand how it works. And we don't yet understand it because well, I've got the ideas, but the nerves respond to local movement over time. So if you do a lot of wrist movement, it adapts well. But if you don't do much wrist movement, start moving it in a neurodynamic test and it might not adapt so well, so it might produce different response. And so we've got more complexities to deal with. Now, Michelle Copper's group and Bob Nee's group showed that if you do the same range of motion with all sequences of a neurodynamic test, the end result in the nerve mechanically is actually quite similar. So for them, the sequencing didn't produce a different strain in the nerve for different sequences. But that's not how we do it clinically, and that's not what happens clinically. If you measure the range of motion of each joint, when you start at one end, the ones at the other end don't move as much. So if I do wrist extension first, it now pre-strains everything, and then I can't do as much lateral flexion. So the wrist is extended more. But then if I do lateral flexion first and then do the wrist can't extend as much because it's pre-constrained.
Right.
So the idea of neurodynamic sequencing not working, it's that in that particular work, it's in cadavers, and they're not breathing much, and they're certainly not moving much. and they don't tell you when they hurt.
Right.
And so you go to a patient with carpal tunnel syndrome, they do. They say, yikes, that reproduces my pins and needles, stop. And then you measure the joint ranges. So the joint ranges are different in vivo from cadaver. So at the moment, it's not fully studied. We're still learning about it. And there are some people who I would use it to help me find out where the problem is. And other people I say, well, having fiddled with both sides and have a good look, I say, well, don't use it in that patient. And that's called skills. And I wouldn't use just that. I certainly would use palpation to localize where a problem is. And neurodynamic testing is part of the evaluation, but I wouldn't use it as definitive representation of where exactly the problem is at this stage.
Yeah.
How do you explain a condition, let's just say hypermobility, the ulnar nerve at the elbow, which we know can be as prevalent as 11% of the population? So do you feel that neurodynamics potentially could help you with the diagnosis of that, but maybe not so much in the treatment? Do you feel that they potentially could have nerve entrapment in maybe the hand and wrist and the shoulder that potentially could be treated there? Or,
yes.
Yeah, so what's your take on that?
Yeah,
really
I think
intrigued me forever.
Yes. Now, neurodynamic tests extract or detect a certain set of mechanisms in the patient. That's really important to understand. And so some people have a certain problem. Of those, if they have a neurodynamic aspect, then you're going to find a neurodynamic test abnormality. But there are other people who have whose balance of mechanisms might be compression and less sensitivity and movement problem, and they don't have an abnormal neurodynamic test. So you can have a diagnosis, but within that, the neurodynamic test gets out a subgroup of people with mechanical sensitivity and possibly mechanical impairment or changes. Okay. Now, usually if someone's got a neurodynamic problem, the nerve actually lacks movement in some situations. And it's been shown with studies now. The systematic review now shows that. But there are other people who don't lack movement, and that's exactly the example of not lacking movement. The unstable ulnar nerve has way too much. That's the lumbar instability of the elbow for nerves. And so it's flopping around, it's rubbing on bone, and it can hurt and become inflamed, of course. Now, if it were me, if I had an unstable ulnar nerve, probably it wouldn't hurt too much because I'm not so active. But if you have a baseball pitcher, that can be a disaster. And so part of what's wrong and why is how are they dealing with it? How are they moving it? What are they doing with it? And so, and this is, I know that in the US, they're getting a large number of young people with elbow problems from pitching and so forth. And but if you don't pitch, you're not going to get provoked by pitching. And so for me, it's also about putting it in the context. Now, neurodynamically, you can test for sensitivity. And if it reproduces their pain, doesn't necessarily mean impairment of movement. It might mean they need stability. So I think the neurodynamic test is much better at detecting what's sensitive rather than what mechanical problem exists in that patient. Now, I think the mechanical problem is part of the whole evaluation and determination, of course, and that's where skills are important. So I'm not sure whether that answers your question, but the neurodynamic test will figure out if that's a sensitive nerve, but I'm not sure. I personally have not been very effective helping these people with neurodynamic treatments. I think they need stability, better movement control, better protection, because they lack protection.
Right. So then, like in our baseball pitchers, what do you think about the ulnar nerve transposition where they permanently bring the nerve forward to the medial condyle?
Yeah, that's, for me, if you're just thinking in terms of nerve forces, then that's a good thing.
Right.
A very good thing. Very good thing. Here's a clinical question for the audience. If someone has, it's a Tommy John, is it a Tommy? No, it's not. No, it's a transposition, not Tommy John. If someone has a transposition of ulnar nerve from where it's normally to the front of the elbow, what is the next neurodynamic test for assessment?
Median.
Yes, thank you. Yes. Yeah, start off as ulnar, but because its location changes, you've got to do a different neurodynamic test after surgery.
Yeah. Yeah. Beautiful.
What do you think about, while we're on the topic of the pitching athlete, there is an epidemic problem of thoracic outlet syndrome now. And of course, they're doing a surgery. The surgery here, I don't know what it's like there, but it's very invasive. They remove most of the scalene, pec minor. They remove the first rib. And it sounds crazy invasive, but actually the return to play is actually pretty high after the players have had that procedure done. The diagnosis is usually by default, meaning, they have clean imaging of their cervical spine and, other areas. And that's kind of the last resort. What do you think?
Interesting.
You probably don't have as many baseball players as we do, but what do you think about this new craze of thoracic outlet syndrome?
Yeah, I hope they're specific about it. And I don't know a lot about that part of it, but I hope their choice of patient is correct. As I've said before, your technique is only as good as your choice of patient.
Right.
And so I really wish. So thank we're in heaven, okay? We're up there and we're entering the pearly gates, and the angel says, "You've been good." So you have one wish, and you can choose anything you want. I would like them to look at the mechanical function of the plexus and scalenes and costocavicular space, clavicle and rib, and all the soft tissues around it, and digitally measure it all during different tasks to see if there's some mechanical abnormality there. So that would be dealt with. And I suspect that the surgery is quite drastic, of course. So it removes the mechanical aspect, or like compression and irritation, but with a lot of extensive changes. And the idea, I think, and the surgeons are doing this, of course, they're doing less and less and less, but doing the right thing more and more and more. And I would hope that with radiology, dynamic radiology, we could measure how brachial plexus functions in that area mechanically in relation to its tissue around soft tissues. To me, that'd be a really good thing to do. And I suspect that the good post-op outcomes might sometimes be related to improvement of mechanics.
Well, I think it's hard too, because a lot of times with them, they don't have the classic paresthesia that you see in thoracic outlet syndrome. They may have shoulder pain, they may have parascapular pain. Their symptoms are just kind of can be a wide mix of a lot of different things. But I think it throws everyone off because they don't have the classic, stocking glove presentation that you learned about in the textbooks,
Yeah, I agree. And, we say the stocking glove, it means it's non-specific and everything. Not necessarily, Part of diagnosis is learning what it is not. And so part of treatment is some way exclusion. And that's same with neurodynamic testing. If you can exclude stuff that competes with your idea, then your idea remains. Mm-hmm. And then you've got something to work with. If you try and exclude it and they fail the exclusion test because the other stuff is there, then it's not so easy. And just to be on a side, we just sent a newsletter out that talks about extending the straight leg raise with other movements, such as internal rotation. And it was highly reliable with the study we did. But okay, it's reliable. What do you do with it? Which is, you could extend the straight leg raise into higher progressions to the athlete, and it's reliable. For me, that's important. It's the extension part. Okay, reliability is obvious. So how do you extend it through thoracic outlet syndrome, the athlete who throws a lot? That's where physical testing and complexity is really important. And for those who've done the course, and you guys have, that's the 3C technique, multi-structural, that is really useful for figuring out what movement problems relate to a patient's pain.
Beautiful. Go ahead.
In NDT, there's a thought. The thought is you always rule the spine out first in a condition. Would you say overall you agree with that statement, or what do you think to that?
Yeah, that's thought? Interesting. Yeah, that's a good question. When we were doing MIPS with Maitland and here and so forth down in Adelaide with the teachers here, Mark Jones and all this, we were encouraged to reason through problems, of course. But prior to that, we were always, exclude the spine. It's a really important part of diagnosing hip problems, for instance, or pelvic problems. But it's only part of the picture. And so at the end of this, all this reasoning we learned was you can also, if you can justify treating the periphery at the beginning through reasoning and testing, then yeah, good. So as a general rule, it could be helpful for a lot of people, but if you reason it through, it should be helpful for everyone. Mm. And so part of physical testing to me is quickly eliminating an idea. So you don't have to go there anymore. You're done. Now you can focus on what's important. So the answer is yes, but with conditions. If you go through a pro forma, you're going to be slower. You're not going to recognize patterns as quickly, and you're not going to identify stuff as easily. But if you're able to reason it, you can quickly eliminate something with a couple of quick tests. Okay, that's fine. No pain referral, good range of motion to the back, strong pressing, no history of back pain. That's out.
Mm-hmm. So I think that's right. I mean, I think
get in the hip.
Clinical reasoning, the process of being able to, to reason well clinically would allow you to know exactly where your starting point might be in the seasoned clinician.
Yeah, I agree. And, I know there's a lot of stuff on artificial intelligence, and it's getting into all sorts of hospital systems and stuff like that. And what I'm learning about artificial intelligence is it truly is artificial. Because it doesn't always work. If you get it wrong, you then have a much more difficult problem because it's progressed, it's more complicated than you thought, and you got to start again. And there's a in the physical therapy there were a bunch of clinical prediction rules that were produced quite a while ago, and the graduates were finding it difficult to solve problems because they were just given a bunch of questionnaires to do. And if the patient didn't succeed or wasn't successful in treatment, the young clinicians were finding it difficult to decide what to do next. Whereas the experienced clinician is able to process more complex problems.
Well, artificial intelligence can never capture the experience that's built into the knowledge of you performing the test, So even if we had a robot that was able to perform a neurodynamic test, and they wouldn't be able to have all that years of history that would be built into that, into that experience.
I mean, ultimately, artificial intelligence will improve. But, when you do a neurodynamic test, like many physical things, you're watching the patient's nonverbal behavior. You're watching their eye contact or their facial expression, and whether they avoid you a little bit as you move. And these are whether they trust you even. These are all parts of physical diagnosis and treatment. And so I fully agree. It's going to be really difficult for any robot to do what we do.
Thank goodness. Yeah, exactly. Could you, if we were doing ultrasound and we had a way to kind of see how the nerves were sliding in and out of the muscles in our extremities, would you be able to predict, Michael, whether or not somebody was having a pain syndrome or not? So, or is the body so adaptable and can compensate to where like that wouldn't be possible because somebody might be able to, get around that? Do you know the question I'm trying to ask?
Is you be able to image something that closely resembles or represents a physical problem and relates directly to symptoms? Is that what you mean?
So if you saw an error on imaging of lack of sliding, would you be able to determine whether or not they would be currently suffering from some kind of pain syndrome?
Not directly, I don't think, but if you're thinking of a spectrum and larger numbers, we've looked a little bit at median nerve movement with ultrasound and stuff, and at the extreme ends of the spectrum, particularly loss of mobility, I think your chances are better. Because we do know that people who have carpal tunnel syndrome definitely do have less longitudinal excursion of the median nerve of the wrist.
Right.
Systematic review. Well, the systematic review evidence now shows that people who have a nerve syndrome do have less movement, or usually have less movement of the nerve, and so. But in the individual, it's much more difficult. And so if it's really at the stuck end of the spectrum, I think your chances are pretty good. But at the other end, not so much, and middle ground. I mean, I remember we did this on a patient with carpal tunnel syndrome and looked at their nerve movement, and it was like tiny. I was doing the bazinga movements on the arm, And we could still produce very little movement of the median nerve. And she had carpal tunnel syndrome on that side. We followed them through the surgery, then re-imaged her. I watched the surgery and everything. Came out, and then she had complete relief of her symptoms a month later, and her nerve movement had returned to normal compared to the other side. It was the same as the other side.
Wow.
Now that N=1 showed in that person that physical changes changed with the symptoms. Now, coexistence is not always an indication of cause, but when they change together in a dose-dependent manner, now you have something.
Exactly.
Mm-hmm. Mm-hmm.
Yeah. So you just had a paper that came out here.
Yes.
Yeah,
I
can
think
you
you're
kind
talking
of
about
tell
the
us what you
clinical
found
trial.
here? The title is Treatment of Sciatic and Lumbar Radiculopathy with an Intervertebral Foramen Opening Protocol, Pilot Study in a Hospital Emergency and Inpatient Setting.
Yes, that's actually, sorry about the long title there, but when you publish research, the title has to illustrate the content of the paper.
Oh, yeah.
And how comprehensively you do that in the title is up for debate. So first of all, we wanted to apply different logic. And the logic in the past has been, if someone has a neural problem from MSK, treat the MSK and the nerve should improve. Well, that's okay. Or if that doesn't work, mobilize the nerve and take it from there. So the two systems are treated separately. That's one thing. And unfortunately, if a nerve is compressed like they are in lumbar radiculopathy, we just apply more force with neuromobilization, which, if thinking of cause, doesn't make sense. A lot of medical practitioners will look at this and say, why would you mobilize a nerve that's already compressed? Why do you want to add force to a nerve? And so probably adaptive, but so what we want to do is flip it on its head and say, look, let's just for a short time ignore MSK. Let's look at the idea of nerve response maybe become part of the cause for now. So all we're going to do is nerve root first aid. We're going to do the nerve root rescue squad, and we're going to take force off that nerve root and see what happens. That's all we're going to do. We're not going to subcategorize patients. We're not going to do MDT, all this sort of stuff. Not that there's anything wrong with those approaches, of course. We just want to just hit it hard, as close to the cause and trigger as possible. And which was just take force off the nerve root in the early phase of acute radiculopathy, acute meaning recent onset, and these were severe as well. So they were recruited or offered. These people came to hospital because limping, because they couldn't walk, pain, sciatica. I need help now. And the general public don't know much about sciatica. They don't know that, usually it's not a serious problem medically, that often resolved and everything like that. But 30% of them or so after a year are still not okay.
Yeah, exactly. I'm assuming the majority of these were discogenic issues, I'm assuming.
Yes. Now, one of the things that we felt we had to do was make sure we know what the problem is, because unfortunately in the physical therapy research, a lot of it is lumbar radiculopathy-like symptoms, like pain down the leg. That could come from anything. So we wanted to make sure that medically we had a diagnosis, and that comes from radiology and electrophysiology. So we did both of those when they got in the hospital, and we established who had neurological deficits objectively. This is not just clinical evaluation, this is electrophys, so it's objective measurement. And we wanted to know the cause, so it had to be single level disc hernia on nerve root. If they didn't have those features, we didn't include them. We wouldn't have included them, okay? So we had to know what the problem is first, medical diagnosis. So we got those. Then they were invited, obviously, they're in the study. And so we could actually, this is why I said in the title, sciatica and lumbar radiculopathy, because sciatica doesn't always come from lumbar radiculopathy.
Yeah, exactly. I figured that's why that was the title.
Yeah, that's why it makes it a long title, but it means there's no dispute at the outset of exactly what the problem is. So that was clear. So the next part was, we wanted to randomize them, of course, that was easy. And then we wanted to control or certainly know what they were doing. Now, one of the problems with any physical technique is that people leave your clinic and they go home and mess it up. They pick up the dogs and drive to work, and they've got that thing in the backyard that they have to lift that they need to move over the weekend. They commute when they're sitting in a car and on trains, and so a lot of clinical trials don't actually test whether the treatment technique is effective. at least instantaneously. And so we wanted to control or know what they were doing. So part of the management was to tell them what to do in hospital and don't do anything else. Okay, don't walk down the road and start smoking when you're hiding behind the building and then have a booze up and then come back into the hospital. We don't want that. We want you to just walk around as much as you can and in the ward, the department, and don't bend forward regularly because we wanted them to move and keep moving their disc, and don't lie on their back because we didn't want them to extend too much because we're doing an opening protocol. So there was medication, walk as much as you can, bend regularly, but stay in the department, okay? The other group had exactly the same, but we did the static opener protocol. And so we could measure things like disability, self-reported disability, straight leg raise. We could do pain ratings and so forth. And so these people were in hospital on average about 8 days, which is a lot more than usual, but that's what they were offered and they took it. And on average, at about 6 to 8 days, these people were much better than the group that did not have the opening protocol. And straight leg raise was better, their leg pain was better, and so forth. And so it's only a pilot study because there's only 10 per group. But one of the reasons we did it was to see if you could study it well in hospital and control things to see if that technique had some potential, and whether it was safe in the treatment group. And so luckily, no one in the treatment group got worse. No one got an increase in pain. One person in the control group did, and they ended up you're getting a small deterioration. So safety prevailed, good. The other thing was that the results were really good. Now, the worst results in the treatment group were still better than the best results in the control group. So there was no overlap in the data between the two groups. And because you also have to do evaluations of factors that might distinguish the two groups, anthropometric, like weight, height, gender, so forth, and severity of pathology and disease. And so we looked at the rates of electrophysiological impairments and dyskinesias and stuff. But overall, there wasn't a huge difference between the two groups. Nothing was significant except for, I think, the treatment group had more neurological deficits, but they still did better. Anyway, it will be available in PDF. I'll get that to you guys. So as a pilot study, we also had to do stats. And I've just learned how to spell and pronounce statistics. And so we had to do those, of course. And so what we had to do was attack it from different angles. Now, if the same results occurred from different stats and different angles, the data is strong. And so what we know about research is that p-value is under pressure at the moment, where you can get a highly significant result with a very small effect size in a large sample. That's because it shows consistency. So one of the things you need to look at in a study is effect size. You get 1,000 people and you improve them 10%. That's over the 0.05 value. But is 10% meaningful in the patient? We have to do then statistical analyses on what the patients are satisfied with and what threshold we would say they qualify for satisfaction or value in treatment. That's called minimal clinically important difference. And so there's a bunch of stats we do, and all of them converge to the same effect: big effect sizes, big people, a large number of people surpassing the threshold for satisfaction, and highly significant results, and only a really small sample size was needed to produce a significant result in the treatment group. Sorry to get a little bit technical, but so the results were so good that we are recommending further study. We can't, we can't, that's not a predictor, of course, but it's a first study of that logic and that approach in people with a known pathology and disease.
Beautiful. I love it.
Yeah, so we're really happy with it. It's been a difficult study to publish because clinical trials are a bit difficult, even when there's small samples. But in the end, they accepted it, fortunately. And for us, it's a really big step forward for stimulating interest in the opener mechanism for lumbar radiculopathy. We're also asked if we will subgroup the patients, such as, the opening, closing, or MDT, stuff like that. And I said, look, that wasn't the intention of the study. We didn't want to subgroup. The sample's too small. We weren't really trying to figure out what mechanical problem they had. We just wanted to take force off the nerve root and see if it works, see if it's got potential. Yeah, so thanks. So that's an example of putting the patient in the neurodynamics hospital.
Yeah, I love it. And see what happens, right?
Yeah,
I love it. Well, what a great conversation. We purposely set this up, Michael, to be somewhat of an overview of neurodynamics. We have big plans for you going forward as far as a couple different part series in our podcast, because there's a more story to tell here, right? Which is important. We didn't get really into specifics of testing, the specifics of neurodynamic treatment and stuff like that, which that'll be for another day, which I'm excited for. But number one, I thank you for your service to the musculoskeletal world of diving deep into this topic. It's easy to be, jack of all trades, but a master of none. I feel like you are a master of neurodynamics, and nobody understands this more than you. And so we're thankful that we've been able to learn from you, number one, and thankful for you being our friend and being able to have conversations like this. So.
Well, look, thank you very much, gentlemen. It's a real honor and a pleasure. And I hope I've demonstrated Gestaltian principles here, because, that's kind of how it works. So
it is.
Thank you very much for the opportunity, guys.
Yeah, beautiful. Well, by the time this airs, hopefully we'll maybe have some concrete courses coming up for 2022. So I know that a lot of people have asked us for Michael Shacklock, and we're going to try to deliver. And so live and in person, but we'll save that for another day too. So if you are interested in neurodynamics, go to neurodynamicsolutions.com. That is the hub. You've got so much great information on there. I know that you're regularly updating content. Is there anywhere else that you direct people?
Yes, thank you. Facebook. Unfortunately, our Instagram account got stolen, and so we would advise you, for the meantime and until further notice, don't interact with it. But Facebook, Neurodynamics at Facebook is where we're active. And if you want email updates, then go onto the website and just put your email in, and we'll register you and help you out. Beautiful.
To stay up for when we announce neurodynamics courses for Gestalt education, go to gestaltedu.com/subscribe. I'll put all this in the show notes as well. You'll be the first to know. Hopefully very, very soon we'll have some concrete dates. And with that being said, guys, if it's very easy to bastardize neurodynamics, and I was guilty of it. I know, Brett, you'd probably admit you were as well. Understanding these principles that Michael's teaching right now will completely change your view of neurodynamics, sliders and tensioners, when to do them. And understanding the physiology and the pathology of these situations will completely change what you do in the treatment room. And reading them out of the book, as good as your book is, Michael, it's not as good as seen in person. And so please get to see these courses in person, because it will literally change what you do tomorrow.
I think too, the reason neurodynamics is part of our core 4 is because if you don't know the principles of neurodynamics, there is a case tomorrow that you can't treat. So that's like, we're not saying you have to use the principles with every patient, but if you don't know these principles, you don't have a tool perhaps for the right patient. And I would just say Michael's a gentleman and a scholar. You know, so it's rarely do you actually have an expert who is fun to be with and humble and all those things that make for good human beings. So
rock and roll.
Thank you, gentlemen. Thank you very much.
Michael, we'll talk to you very, very soon. For the rest of you in Gestalt Education Nation, check out Neurodynamic Solutions, subscribe to our email list, and have a great day. Good luck with patients, all right? I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.